Hi everyone. This is our second presentation for Unit 2. So here we're going to be talking about the different wound assessments and care. We had already learned about the different kinds of wounds and how to classify them. So now we're going to learn about how to assess them. Prior to assessing the wound, we want to gather some more information. Some of the information we want to know is about the wound specifically. So we want to know what kind of wound is it? How long has that wound been there? What did it look like last time? Are you expecting to see it infected? Is it painful? If it is painful, we might want to administer some analgesics prior to assessing our wound or doing a wound change or dressing change. We want to gather some information about the patient. So we want to learn about their nutritional status. Are they consuming enough protein to heal? We want to look at the patient's risk factors for their adequate healing. We want to look at the risk factors for re-injuring. We want to learn if the patient has any allergies, and potentially we want to know if the patient has any allergies to the adhesives that are used in dressings. We're going to want to take a look at the external dressing. So is this external dressing, is it intact? Meaning, is it all still in one piece? Is it dry? Is there any shadowing? So shadowing refers to the visualization of the fluid buildup underneath the dressing itself. And then, of course, we want to obtain consent and explain the procedure to the patient. Next, we can move on to the assessment of the actual wound itself. So we've already identified the type of wound it is. Next, we're going to be looking at the location. So while we're assessing the location of the wound, we're going to need to be exact. We need to use correct terminology. For example, we need to state right lower quadrant or left lateral malleolus. So for size, we want to look at the length, the depth, and the width. So the length is referring to the distance from the heel to the toe. Width is from side to side, and depth, how far does that wound go down? We want to look at the surrounding skin. So what are the wound margins like? We want to look for any redness, any induration, meaning abnormal firmness, any undermining, the temperature of the surrounding skin, moisture, drainage, color, if there's any odor. Any redness around the skin or the surrounding skin or the peri area may indicate infection. We're going to look for odor. So is this odor a foul smell, a fecal smell, a musty smell? Then I'm going to look at the drainage. We're going to discuss drainage a little bit more in a few slides. So we're going to look at the color, the amount, the consistency, and the odor. We're going to look at the temperature. So we're going to palpate the surrounding wound, so the surrounding skin and the peri area, and see if that temperature is increased or decreased than it is to the other areas of the body. We're going to assess to see if that patient has any pain. So we're going to use a scale of 0 to 10 to assess the patient's pain, or we might have to use a different sort of pain scale dependent on the patient's ability. Severe pain may indicate a fresh incision, or it may indicate an infection or underlying tissue involvement. Typically, we see the pain decreasing as time progresses, but if the pain is increasing as time goes on, that is an indication that we need to do further investigation as well. Then wound closure. So we're going to look and see what kind of closure devices that this wound may have. So do they have sutures? Do they have staples? Do they have any steri strips or glue? And what are the state of those wound closure devices? So are they still appropriately holding that wound together, or are they pulling apart? Some common assessment findings for altered skin integrity. Approximated edges. So this refers to the edges that are close together. So edges are touching each other, means they're approximated. And this is only when the patient or the wound itself is healing with primary intention. And look if there's any crusts that have formed from exudate along the edges. This is common. This is normal. If the edges are inflamed, if it is within the 2 to 3 days after the formation of that wound, that is normal. If it extends longer than 2 to 3 days, it is something we need to look into. Is there any skin discoloration from bruising? Might have some purple or blue or yellow or brown, depending on how long it has been. So this is normal. A red wound face. So this means that there is healing tissue or granulated tissue. A normal wound is non-odorous, so it typically doesn't have an odor. We've already discussed pain, how pain should be improving from the previous days. Normal exudate is serosang or serous and in decreasing amount. Again, we'll talk about the different type of drainage in a few slides. And typically, if it is a surgical wound or a primary intention wound closure, we expect no exudate after about day 3. So the assessment of that drainage or that exudate, what it looks like. So serous, which is a clear watery plasma. So that's first box here. Next we have sanguinous, which is bright red or indicates active bleeding, which is this bottom right-hand box. Then serosang, which is a mixture of the plasma and the blood, having a pale red and watery. So one of the biggest difference between the sanguinous and the serosang is the consistency. Serosang is more watery than sanguinous. And then last we have purulent. So this is a thick drainage. It can be yellow, green, tan, or brown, and this indicates an infection. We want to document the amount of the dressing that is saturated as well. While we're documenting the amount that the dressing is saturated, we want to use percentages. We don't want to use mild, moderate, or severe. We want to state percentages, as percentages tend to be a little bit more transferable from patient to patient. Whereas for this one, I may say 20% of this dressing is saturated with serous dressing. But I might also say it was mildly saturated with serous dressing, whereas somebody else might say it was 25% saturated or moderately saturated. So the difference between 20% and 25% is very similar, but the difference between mild or moderate can be quite significant between two different patients. So making sure that you use that percentage to estimate the amount of drainage on the dressings. This is just a picture of some drainages just to get a further understanding of the different types. So on this first picture here, we're going to see mostly serous drainage. You might see a little bit of serosang drainage here. In this picture, we're seeing mostly purulent and a very large amount. I would say this one's probably about 90% saturated for the dressing. And this last one, this is also a purulent drainage. Whereas this one, since there are 2 different layers of dressings, we're going to need to label the amount of dressing saturated for each one. So the first layer would probably be about 80% saturated, and then the second layer probably about 10% saturated. And both of those are very important to document. After we have assessed the wound, we can move on to measuring and describing that wound. So we will want to start off with measuring the width and the length of the wound. So we're going to use the widest and the longest sections of that wound. And we can use a sterile cotton tip applicator to help us measure that wound itself, just as this here. So holding that cotton tip applicator above the wound and using the tip of the applicator and then your thumb to mark the areas of the length of the wound length and the width, and then comparing that to a ruler. We will want to use a clock to demonstrate the time or the placement of the different wounds as well. So if the widest part of the wound was at 2 o'clock to 10 o'clock, we will want to document that. We want to look at the depth of the wound, if it is applicable. And we'll also do that using a sterile cotton tip applicator. So we're going to insert that into the wound. So the cotton tipped into the wound, and then using our thumb to mark the level of the skin, pulling it out, and then comparing that to the ruler as well. This is another aspect where the 12 o'clock, where the clock comes into play. If this is where we had measured, we're going to want to say at 4 o'clock, the wound is 4 centimeters deep. 11 o'clock, the wound may be 1 centimeter deep. So we're going to want to label so we can accurately mark and follow up with this wound. It is important to record in centimeters and not millimeters. This is just a photo showing how to measure any undermining, so that any aspects of the wound that go on or protrude underneath the skin. So this one here, we can see there is undermining of approximately 1/2 centimeter, or the tip of that cotton tip applicator. After we have measured the wound, we can move on to assessing the base of the wound. So there's a couple different descriptors that we can use to measure the base of the wound, one of them being black. So if we're documenting a wound as a black wound, this indicates an eschar or a necrotic tissue, which is a thick, leathery, dead tissue. This tissue usually needs to be debrided, but in some cases where people are terminal or healing is poor, that eschar should be left alone to cover the wound. So that eschar is left alone on arterial wounds, which we've already discussed in part 1 of this unit. Now we have red wound base. So a red wound base is a good wound base. So this means that the wound is healing. This is the formation or the visualization of granulated tissue, which is healthy tissue. This wound is then in the inflammatory or the proliferatory stage of wound healing. And this wound needs to be kept moist and clean. You may see a yellow base. So a yellow base is from a wound that is not ready to heal. And this is due to a fibrous slough or old tissue or exudate. This exudate or the old tissue needs to be cleansed and removed, but it might take time. For a wound that is non-viable tissue, a nurse needs to include the amount or the percentage and the appearance of the color or the viable and non-viable tissues. This will assist the nurse in developing an appropriate plan of care based on the wound care healability. You may also see something with a combination of the color. So here we see some red tissue, some yellow tissue, and some black tissue. When a wound has a combination color here, we will describe the wound as the most severe color, which is black. Once we have assessed and measured our wound, we can move on to cleaning our wound. Northquest has identified 3 different types of cleaning for a wound. We have clean, aseptic, non-touch, and sterile. I will do a brief description of each in the next 3 slides, but you will go over more in depth and practice each technique in lab. So the first type of cleaning technique we have is called a clean technique. So this is not sterile. This is used on patients or wounds that have a very low risk of infection. And it uses a combination of both non-sterile and sterile objects. This is often used on established G-tubes or wounds that have healed to the point that they are going to heal, that we are no longer worried about the infection. We have aseptic, no touch. These are on wounds that have a risk of infection of moderate to high. So these can be surgical wounds that are older than 72 hours, chest tube dressings, or drain sites. Again, this uses a mixture of sterile and unsterile objects, and the sterile to sterile principles apply. We'll discuss the sterile to sterile principles in a few slides. So we will use sterile solution, gauze, dressing tray, and forceps, but we will use unsterile gloves. So these are just the regular bedside gloves. And lastly, we have the sterile technique. So this is when the risk of infection is moderate to high. It is used when wounds are open and complex, meaning we are making contact with an internal organ or entering a sterile body cavity, or there are multiple layers involved or multiple organs are susceptible to infection. This only uses sterile objects. We cannot have any unsterile objects near the sterile field, and we must wear sterile gloves. Once you have a sterile glove on, you can only touch sterile objects, which is part of the sterile principles, which we will go over here shortly. There are 7 different sterile principles. We're going to go over each of them in the next 7 slides. So these sterile principles apply to the sterile dressing changes and to the aseptic no-touch dressing changes. The aseptic no-touch dressing changes, all sterile principles do not apply, but for the sterile dressing changes, all sterile principles do apply. So sterile principle number 1 of 7. A sterile object remains sterile only when touched by another sterile object. This means you can only touch your sterile field with another sterile object. If a sterile object touches something that is no longer sterile, so for example the patient's skin, then it is no longer sterile. And you cannot return that sterile object back to the sterile field. Sterile principle 2 of 7. Only sterile objects may be placed on a sterile field. Sterile principle 3 of 7. A sterile object or field out of the range of vision of an object held below a person's waist is contaminated. So this means if any object goes below your waist or below your working height, it is then considered contaminated. If you turn your back to your sterile tray, that sterile tray is then considered contaminated. So we need to be careful and cautious about how we're setting up our sterile trays in relation to our wound and in relation to our garbage to make sure that we are not dropping our hands below our waist or turning our back to our sterile fields or to our wounds. Sterile principle number 4. A sterile object or field becomes contaminated by prolonged exposure to air. Sterile principle number 5. When a sterile surface meets or contacts a wet, contaminated surface, the sterile object or field becomes contaminated by capillary action. So we need to ensure that the table that we are putting our sterile tray on is clean and dry before we put open our sterile field on top. And then when we're pouring our sterile solution into our containers to use to clean our wound, we need to make sure that that sterile solution stays inside the water container or the waterproof container, that it doesn't splash out onto any other sterile objects, as they will then become contaminated. Sterile principle number 6. Fluid flows in the direction of gravity. So this means that if your forceps are pointed upwards while you're holding them, the fluid flows in the direction of gravity, so it flows down. And then if you go to point your forceps down, that then fluid then goes from where it flowed down to the tips of your forceps. So then it is potentially contaminating your forceps. And our last sterile principle. The edges of a sterile field or container are considered contaminated. So the outer border, so the 2.5 centimeter border around a drape is contaminated, which means objects or gloves that touch this are considered contaminated and they are no longer sterile. So what are some automatic breaks in sterility? A sterile object that leaves your field of view. Contaminating a sterile field with a fluid or a sterile field becomes wet. Dropping your sterile hands below your waist or your elbows. Previously opened sterile packages or containers. sterile objects touching a contaminated object. So there is no 5-second rule. Even a most minute contact would still contaminate a sterile object. So this is just a visualization of a sterile field. So sterile fields are used on both aseptic no-touch and sterile techniques. They are not used in clean techniques. So prior to opening your sterile field, you need to inspect your package prior to opening for signs of compromised integrity or sterility. As previously mentioned, we need to make sure our bedside table is cleaned and dry prior to opening or setting our sterile tray on top of it. Then we need to adjust our bedside table to working height. The order of setting up a sterile field will be discussed in lab. Once we have opened our sterile field, we may need to add some more sterile objects into our sterile field that we will need throughout our dressing change. These sterile objects can only be placed on a sterile towel or a drape to be considered sterile. These objects cannot be placed in the outer 1.1 inch or 2.5 centimeter perimeter, as that is considered contaminated. We can open a sterile package without contaminating the inner object. We do that by banana peeling the package open. So similar to what is open in this, or what is shown in this picture here, the two outer layers of the package is folded back to reveal the inner contents. The package is not ripped or not cut. They are folded back in an open manner, so this inner contents do not become contaminated. We can then either place that sterile object gently onto the sterile field using the sterile package, or we can take some forceps or a sterile object and grab that sterile object and then place it down on that sterile field. This is something you will practice in lab. We may need to add a sterile solution, so a sterile fluid to our field as well. We need to ensure that we pour that solution slowly into the sterile reservoir to avoid that splashing. This is just a visual of the two different types of techniques that do involve a sterile tray or sterile field. So the first technique, the aseptic no touch. So this here is our dressing tray. So our field is open. We have our gauzes, our dressings, our dressing tray, all in the inner aspects of our sterile field. The outer 2.5 centimeters are contaminated, and our forceps are half in the contaminated and half in the sterile area. Why are they half in the contaminated, half in the sterile area? That is because we are using clean gloves. We're using the blue nitrile or the bedside gloves. So when we touch the outer aspects, or when we pick up our forceps, the areas that we touch are no longer considered sterile. But we did not touch the tips, so the tips are still considered sterile, which can then touch the gauze, the dressings, and the dressing tray. But when we let go of those forceps, we do not want to put the unsterile area of that forceps on the sterile part of the dressing tray, or the dressing field, sterile field. So we want to make sure that we put that tip in the sterile field and out of the sterile field as applicable. Next, we have the sterile technique, where everything is on the inside of that dressing or that sterile field. So we have sterile gloves and the forceps, which lay inside the sterile field. So our sterile gloves we can use to touch our gauze, our dressings, and our dressing tray. We can touch those with our gloves. Whereas aseptic no touch, we had to use our forceps to touch these. Sterile technique, we can use our hands as we have the sterile gloves on. Now that we have our sterile field open, we can move on to cleaning the wound. Before we clean a wound, we need to check with the physician's orders to note if there's any special solutions that they want us to clean the wound with. Typically, we clean with normal saline, but sometimes a different antiseptic agent is ordered. We wipe from clean to dirty. The wound is considered the cleanest, so we go from the wound out, so center out. We follow the principles of sterile technique. We use 1 gauze per swipe. We need to dry the peri-wound and the wound. So there's 2 different patterns that you can follow dependent on the amount of exudate that your wound has. Start with this one, most common, going 1 right down the center of the wound, and then directly beside the wound away from you, directly beside the wound closest to you, a little bit farther away, and a little bit closer to you to clean that area of the wound. Whereas this one, if the wound has a little bit more exudate or is a little bit dirtier, we can take 1 and go out and follow the motion down. As we're cleansing the wounds like this, we need to be mindful of the way that the patient is situated, and that remember the sterile principle that the fluid flows in the direction of gravity. So if this patient has a part of their body that is higher than the wound, we want to clean that part first. So we don't want to clean this part of the wound and then clean this part of the wound to have the water or the drainage from this part of the wound seep down onto this part of the wound. So if we clean this first and move our way down, then we are leaving clean areas of skin. Here we go. So ideally we want to position the patient so we can have the wound as their highest point, their highest area of the body, so fluid flows on either side of it. The next type of wound cleansing we have is called wound irrigating. So this is used in complex wounds, but it can also be used in closed wounds. So this is where a PSI of 8 to 15 is used to cleanse the wound. So it's flushing the wound out with a low consistent pressure. We can either use a 100 ml sterile saline bottle or a 30 ml syringe with an 18 gauge angiocatheter. So this photo here has a 30 gauge syringe and then an 18 gauge angiocatheter on the end. So we're going to push that fluid or make that fluid flow directly into the wound and then have that fluid flow out. We cannot irrigate a wound that we cannot see the base. We need to be able to see where that wound ends in order to properly irrigate it. And we need to make sure that we dry the peri-wound. That is the end of our second section for Unit 2.